for questions. Yes.
Hi, my name is Mark Sorrell. I'm from Abbotsford, BC, just north of the borders. One of the things about adolescent healthcare that I would like to ask the panel is, in terms of consent, to have good consent, it has to be informed consent, and sources of information and knowledge come from different sources. So we talked about self, we talked about parents, we talked about, of course, society represented by laws and statutes. But how about the invisible forces, what I consider invisible forces, media, for example? I would like to perhaps get some input from the panel about the role of the media in terms of informing or misinforming adolescents. We often see the media portraying, for example, teenage pregnancy or drugs as a sort of a cool thing, whereas they often portray parents as a bunch of, stupid bunch that goes around with their heads cut off. And you often see that in the media, that the parents in movies, for example, the parents are wiser, the kids are wiser than their parents. The other invisible force would be other health providers, chiropractors, naturopaths, who often give advice, say, about immunizations, the human papillomavirus. We have a big kerfuffle in BC about the human papillomavirus in terms of adverse effects and things like that. But this is also magnified by either the media or other health providers who really don't know everything about immunizations and should not be giving advice. So how do we deal with those invisible forces?
I'll start on it. So I think that there's a great New York Times cartoon, there are many of them, one where the person comes in and says, I want that treatment I heard about on NPR. And it's clear that physicians are going to have to spend quite a bit of time dealing with sources of information that come from different places. It's not always bad information. So there are some great public health efforts right now to acknowledge the fact that adolescents in particular, but adults also, get a ton of their medical information from media sources, and to think about ways in which to get that information out there in very savvy ways. In fact, there's some great public health efforts to get information to adolescents through text messages, which turns out to be a great way, from what I hear from parents too, to communicate with your adolescents. They won't talk to you, but they'll text you. So physicians and health professionals are picking up on that. So I think there's a plus and a minus. You don't want to ignore that it's out there. You will obviously need to spend some time responding to it. I think this is true with your adult populations also, but it can be used in creative ways. And particularly with a population that is very sensitive to where they're getting their information, and media might be a particularly good way to communicate. It depends on the media, but various forms of media might be a good way to communicate with your adolescent populations.
I very much agree with what Jessica just said, but I'd like to add that from a legal perspective, the information that adolescents may be getting may, as a practical matter, influence their decisions and their choices, but it's not part of the information, unless it's communicated by text message or something, that the healthcare professional is providing as part of the formal informed consent process. So I think there's kind of a delicate balance between recognizing the reality of adolescents' lives and where they're getting their information and what's influencing their decisions, and keeping in mind what the legal standards are for what kind of information has to be part of a formal informed consent process.
I think what I would add to that is just as a practicing provider in a community, understanding what information they may be getting is important as well, just to, because there's no filter on most of the information. They get great information, they get bad information, it's equal to the kids. And giving that time and maybe even participating in the community and helping increase health literacy is helpful as well.
And if I could just underscore the global health perspective on this, I mean, I think just, to follow up on what you said, there's some really creative efforts underway to use cell phones, texting, peer networks, and to use the media for public health efforts to reach kids who we haven't talked about yet, kids on their own, street children, orphans and vulnerable children in the global health context. So again, to follow up on Leslie's comment, it needs to be filtered, and that's the real critical challenge, is how do we filter this through adults that are there on the receiving end when they're trying to digest the information. And you get the telephone game, right? They share the information with each other, and the message can sort of mutate through that process. So it's not without challenges, but I think it would be a mistake to not see the potential benefit and really life-saving benefit in some cases of the media.
Next question.
Hi, it's Stefania Shear from Seattle, Washington. So I'm very curious about this idea of a surrogate consent, and especially in trying to determine who has the best interests of the patient. And this is not an uncommon scenario that I'm treating a patient with a chronic disease, and the foster mom's in the room, and the genetic biological mom is still involved, would love to get back to having custody of her child. And I'm trying to decide what treatment to do, and the overworked caseworker who's in her office is actually the person who legally, I'm told, has the best interest of the child in mind, and I must get consent from that person. Ideally, all 5 of us would be in the room and we'd decide what would be the best thing, but I find that it would be I don't know if the law has any recommendations or has had any guidance in allowing the foster parent to have a little bit more say in actual decisions, because that's the person I'm actually deciding what procedure to do. The other people are in the periphery, but that whole communication that happens is not with the person that I ultimately get consent with.
So to the extent that it would speak to it at all, and although states have usually they have mechanisms in place. All of them have mechanisms in place for decision making for incompetent patients. Not all of them have direct surrogacy decision, surrogate statutes versus advanced directive statutes versus proxies. To the extent that they would talk about it, it might talk about it in the context of what kinds of things the surrogate decision maker should take into account. And guardians too, like I said, the law just sort of said guardians have authority. So if this person was put in place as the legal decision maker, one might assume that they were put in place under a guardianship statute. But then the guardianship associations have started to really push as a professional association to say, well, your responsibility is to take into consideration these additional factors and this additional input. So to the extent it allows it to come into play, it might not be directly in saying, well, you can bypass the person who has the legal authority and go right to the person you want to talk to. But it would certainly accommodate having the foster mom be part of the decision-making process, especially to the extent to which you can say, look, that legal decision maker has him or herself an obligation to gather appropriate information from the people that know this child the best in order to make the analysis they have to make the decision. They can't make it in a vacuum. So I think the law is pretty flexible there. The other thing to keep in mind with a lot of these decision-making contexts is that the vast majority of them happen outside of legal purview. So, much of it I tell practicing physicians all the time is, to think about what you need to be doing in that case. You need to be careful, and I think that earlier the comment was, don't ignore the law. Don't not know who the legal decision maker is. You might, in fact, need that person's signature on something. But that doesn't mean you might not have a number of people that you talk with or in the room who you're gathering information from and trying to make a decision. So the law would accommodate it, but it might not do it by having somewhere in a statute saying you could do X.
There's actually one state that I know about. I think what you described is fairly typical in terms of, the social worker or the court having designated to someone, responsibility for making medical decisions for children and adolescents in foster care. California actually has a statute that says that foster parents can make decisions with respect to, and I can't remember the word is routine or ordinary care. And then, of course, does not define what routine and ordinary care means. I would say probably brain surgery wouldn't fall into that classification. But a statute like that, which I think is quite rare, could be helpful in the situation you're describing, although the commentary that you may need somebody's technical legal permission, but you may want to involve someone else is really, I think, the valid approach.
And I think, Mark, you talked about that a little bit also when you were talking about having someone you trust in the room. as well as someone who may be the legal. Do you want to comment on that?
Sure. Yeah, I would say with regard to an adolescent mother, particularly an early adolescent mother, which was the focus of my talk primarily, that with regard to the adolescent mother, I would say that at least the first attempt would be someone that she trusts and that she says, I want to bring my mother or I want to bring my aunt, but to encourage her to bring someone in that she trusts, and to deal with both of them. Now, at some point, if the state ends up assuming legal authority over the infant, I think every effort should still be made to include the child's mother in the conversations and the decisions as much as possible.
Okay, at the front microphone.
Abigail, you reminded me 2 years ago with Angela Holder, we had an interest group on ethics and the law in the meetings of Society for Adolescent Medicine. And at that time, one of the issues that was really very preoccupying was the issue of states that mandated physicians to report sexual activity of minors. And I was wondering, that was 2 years ago, what has happened since? Have people been prosecuted for not reporting? Is actually reporting going on? Are conscientious objectors to this law accepted? What has happened to all that? There was a lot of flurry 2 years ago.
Well, I don't know whether there's continuing flurry, but there's certainly continuing activity and attention to this issue of when the consensual sexual activity of a minor needs to be treated as a form of reportable sexual abuse. And there is no consistency among the states as to when consensual sexual activity of a minor has to be reported. And there is no consistency, often even within a state, as to how the prosecutors in a particular county are treating that, or how the child welfare agency in a particular county is responding to those requests. And I think it has created a lot of questions and uncertainty on the part of particularly practitioners who deal with adolescents around sexual issues, who believe that it would be advisable for adolescents to wait until they're older, but who also recognize that not every instance of a 15-year-old having sex with a 17-year-old or an 18-year-old or even a 20-year-old is necessarily child abuse that should be reported. The federal government, for a period of time, has put much stronger requirements on, for example, Title X family planning clinics to report sexual activity under child abuse reporting laws. And I would say there is not yet any clear across-the-board resolution, but there also, to my knowledge, have not been significant instances of healthcare professionals being prosecuted. It's more that they've been caused a heightened level of anxiety about this. The Society for Adolescent Medicine, the AAP, the AAFP, ACOG, and the AMA issued a joint policy statement saying healthcare professionals should report sexual abuse, but should not be required to report every instance of voluntary sexual conduct of adolescents.
And again, if I could just chime in on again from the global health perspective, and one of the things that we run into in the context of large institutionalized settings or orphanages is that, particularly for the kids that are in a temporary fostering situation, the effects of disclosure of abuse are enormous. The cost to them of losing their temporary situation with an auntie or with, a distant relative or even a neighbor. If they report that uncle, they've now lost, the only semblance of a family situation that they have, even though a horrid one. So it's really important to look at the full context so that disclosure and help and intervention is done in a way that tries to find either a substitute living arrangement or something and protects them from further or even worse abuse as a consequence of that disclosure.
That's great. The back microphone.
Thank you. My name is John Geisiger with Doctors Opposing Circumcision here in Seattle, and I have a broad question which actually I already asked Dr. Walker, and she gave me a wonderful answer, but I wanted to hear what the other panelists had to say. It seems to me there's research out there that shows that physician contact with the patient is something around 5 minutes per patient. You've given a wonderful presentation, all of you, in the day and a half we've been here on the complexities of this issue, and I don't see how we square the demands that are put on you for this high level of considering about consent, whether with minors or adults, with the limited time physicians have available with each patient. Thanks.
I can tell you how that gets resolved in my own professional life, and how I think it gets resolved for many of my colleagues and the people I work with. What some people refer to as the old 80-20 rule, which is basically that 20% of the patients take up 80% of our time. So while I cannot give, if I'm supervising 15 or 17 intensive care patients, I cannot give each set of parents an hour of my time every day. It's simply not possible. However, it's not at all unusual to give one or two sets of parents an hour of my time each on any given day. And so we tend to go where, as attending physicians, where our attention is most needed. So it's actually, for these very difficult cases, it's not unusual to put in a great deal of time. The reality is, it's at the expense of the patients where everything is going well. And some could say that that's a shame. Others could say we're simply trying to do the best we can for all the patients. And the analogy would be the medical care. Some medical problems I can solve in 1 minute, and some I can spend an hour on to just barely come up with a reasonably adequate plan. And so that's what I do. I put the minute here and the hour there. And I think the same is to some extent true with communication with families. So actually, the really difficult situations like this, they do get a lot of time by the attending physicians. Maybe not enough, and there's no question we're limited by practicalities. But it's not a simple equation of how much time per day we have per patient, because these patients and their families take up a disproportionately large amount of our time, and I think that's appropriate because they need it.
One of the things we talked about in the break that I'll mention, I think it's important, is when I gave my talk, I said the word provider, and I tried really hard never to say doctor, because when a patient comes in, their whole experience, probably the minimal time is with the doctor. They see the check-in person, they see the nurse, they may see an MA, a medical assistant. They see a number of people, and then they see the doctor. And their experience is not that fragmented. They see it all as one experience. So when you're talking about trying to work on these issues, it's not all on the burden of the doctor, and it shouldn't be. It's the whole experience and everybody beginning to try to work on these situations. Sometimes it's the nurse that hears this sensitive information, and that person can begin to address it. There's a lot that everyone as a team could do, rather than saying, okay, in that 5 minutes, you have got to get this family from this conflict to resolution and action, and that doesn't happen. The other thing is that I do think it's unfortunate is with adolescents in particular, there are a number of providers who actually don't want to see adolescents because they don't have the time, and so it kind of constricts who they get to choose to see, and so that's why I think a lot of these issues don't get addressed. When I first started working after fellowship, I came to a place and I asked, well, what are the STD rates? I was in a new place, and they said, oh, no, our kids are really nice here. We don't have these problems with our kids. And the problem was nobody was asking the questions. So when I got there, I think I really increased their little statistics because I started asking the questions. But I think avoidance is how a lot of people deal with it.
The front microphone, Annie.
Hello, Annie Janvier, Montréal. It's basically a question for Mark, also being a neonatologist and ethicist, whatever that is. What you're saying, I think it's self-obvious when you work in the NICU. The adolescents who have kids, there's kind of two kinds of adolescents. Those whose mothers, who often had them as adolescents themselves, are there all the time and embraced that pregnancy and sheltered that, gave a growing environment to that adolescent, and other parents who kicked the adolescent out, who started selling drugs or went in shelters. And these two populations are very different. For one, you don't need to say bring in a significant other. The grandma, who's younger than me, who's already young, is in the room all the time. The grandpa's there all the time, and they take decisions together. The grandma had her kid at 15, who had her kid at 15, and the great-grandma's 40. And so the families are there. And the real problem then is the ones who are in shelters, who started doing prostitution, selling drugs. By disempowering them and calling the youth protection, it's not serving them well, because they tried to emancipate themselves, keep this pregnancy, they got kicked out. And this is the moms I have the most problems with, because you're trying to make them responsible physicians. They've tried to do something for themselves and not get an abortion and do it by themselves. And this is where there's no significant other person. There's nobody. Or you declare them to youth protection, or you're there's a no-win situation. I'd just like to have your thoughts.
I think, Annie, I may have gotten some of it, but not all of it, because I'm having trouble with my ear. But is your idea that basically we're disempowering some parents, some adolescent parents, those who don't have their family support?
Yeah, and most of adolescents, when they carry down the pregnancy, well, in my opinion, but Canada is different, the moms also had them as adolescents, and they're there. It's kind of normal to have kids, and it's easy. This is the easy case where the grandma, you don't need to say bring in your mom, the mom's there, or bringing somebody. It's really those who were kicked out of their house because they got pregnant, or kicked out of their social system, who tried to do it by themselves, who need protection. And often what we do as doctors is, she started doing prostitution, using drugs. We call in youth protection. And if you ask these alone kids who are in shelters, or who run away from shelter housing, and they don't have a significant person. They're alone, and we're not empowering them. And I don't know what to do with these moms.
I hear you. You make a very important point. I agree with your point, except that I would turn it around in a couple of ways. One is that to take that 14 or 15-year-old mom who's in a shelter and to treat her as if she's much older and much wiser does not necessarily empower her or do her any favors. Moreover, I think if I take a look, if I have 2 infants in my care, and I say that there is some minimal threshold that I expect the decision makers to have reached in order to provide appropriate care to those kids, that both of those newborns under my care deserve that, including the one who has a big extended family and the one who doesn't. Now, it's not, you can't treat everybody, you can't be exactly the same, and it certainly is problematic. And I don't pretend to have all the answers. I think your point is valid. I would say, however, that for that early adolescent mother who's in a shelter, who's been apart from her family, I think she too should have an adult who works with her through this process and who, along with her, speaks for the child.
Ben.
Yeah, Ben Wolf, I'm from Seattle. Actually, I wanted to follow up on that question. Annie actually asked the question I was going to ask. And so I can ask in a slightly different way and also ask the panel to get involved in the question too. So, Mark, as you pointed out, in the situation that Annie described with a young adolescent who's a mother who does not have a social support system, it's easy to say, well, we should have an adult. So my question is, pragmatically, and this is for the whole panel, what are your thoughts about how to do that? Because it does strike me that by thinking of both the infant as well as the adolescent as a patient, in the sense of somebody who we ought to be caring for and trying to work with, that idea is a good idea, but pragmatically, what are your thoughts about how we accomplish that?
When I've been in this situation, one of the things that you find when you work with kids that don't have any formal networks, that they tend to have informal networks, and trying to tap into those informal networks, the friend that they live with when they're on the street, or the friend that takes them to the shelter, working with them, and also just creating a supportive community for those kids. Because if they keep coming back to you, they're seeing you as a part of their community. And I've had occasion of having a youth like that before, who had a baby, who was homeless, whose family had severed ties with her and did not want to have anything to do with her or her child, and she had mental illness. And you have to create a community, and during the course of time of seeing her after she had her baby, we saw the baby become more and more disengaged. And when she brought her with her for her visits all the time because she had nowhere else to take the child, so we got to see the child begin to look unhealthy, and we had to go, where is this child going for pediatrics? So we began to work out a system with the pediatrician that saw the baby. We saw them at the same, every time they came in, they would call and say, hey, the baby's in, and we had to make a community for that young lady and involve her network of informal people that maybe you might not want to call her support network, but that's what it was, to keep her safe, keep her housed, keep her with clothes, and keep her coming in because she needed a lot of help.
Does anyone else on the panel want to comment on that?
I'll say a little more.
Go ahead.
I'm going to say more about this later, but there have been a lot of successes with informal peer networks. Again, the peers have to be trained by adults, and most of the studies show that if you could even find one adult to mentor a young mother in that circumstance, that it has a huge protective impact. So it doesn't create autonomy or good judgment or good decisions to just blanketly treat them that way, but by trying to create the supportive circumstances where we can help them to make those responsible decisions going forward, that tends to be effective. And so there are volunteer organizations, there are some federal programs where they will match up youth who are homeless or in a shelter with either an adult mentor or a peer mentor. So those are some successful interventions.
And just one final thought, and I don't claim to have the answer to this problem. I would say that I've put forward one proposal to begin the discussion. I think the status quo basically clearly needs to be revisited and revised. But the answer's been to the pragmatic question is, and I realize it's not the same, but let's say for the sake of argument that 14-year-old completely disappeared from the scene, that she left and was never heard from again. We would have no trouble identifying an adult who speaks for the child. We would find somebody who speaks for the child. I'm not saying that's what we should do in the case when the mother's still around. What I'm saying is that there are ways to do this, to find people who can speak for a child. And I would also say the temptation for me, because I'm a really, really nice guy and an insightful guy, and so I can just speak for the child myself. And I think that's a temptation that we as clinicians need to avoid, that this is part of the, I use the term checks and balances, but this is part of the overall care the child deserves. It's not, there needs to be someone else besides me who's speaking for this child.
Front microphone.
Hi, my name is Roy Sims. I'm a primary care pediatrician over in Eastern Washington. And one of the things that I do is I help out with children in foster care. And I think what the state's trying to pilot in this state is a model where whenever a child is placed in foster care or moved from one home to another, the parents are invited to gather together a team called a family team decision-making meeting. And actually, they then reach out to their community of whoever they see as supportive, whether it's a teacher or a minister or a neighbor or a parent or whoever. And I've had an opportunity to attend a couple of those, and I think that what we're struggling with is having them facilitated in a really professional way. But I wondered if you thought, because what you were saying about, it's been years since I've done neonatology, but it's fascinating to think about who would that mother ask to come to the room and to listen and help to make that decision. So I wondered if you thought that was an interesting model to work on.
I think that's a very interesting idea. And I think that, for example, for many people, clergy is an option, and there are others who they would use. I would have to say that in my experience, perhaps because there's not a facility, there's not a huge facility for these adolescent mothers in New Haven that I'm aware of, so that in my experience, most of these young mothers have family that to some measure are involved. And so I do think, for the reasons that I outlined, that family's not necessarily the answer, and not every kid has family, but I would suggest that family is probably more often than not the answer. And so the interesting pragmatic problem becomes when family's not the answer, either because they're simply not there, or because they're there, but they're really not the appropriate answer, because not every grandmother is like my grandma or your grandma. And so, I get that. that I think that the family is the first place to look, but it might not be the appropriate choice. I think that there's all sorts of interesting ideas, like you suggested. And exactly how formal this should be, no, I haven't fleshed that out. I do think that there are other places to look, and your idea is a very interesting one.
Back microphone, lady.
Yeah, thanks for a great panel. Lainey Ross from Chicago. So, Mark, I love your idea of having mom and grandma making decisions, but here's the problem, and just tell me how you're going to resolve it. What happens when they disagree?
Yeah.
Who has the final word? Because in a sense, that's who the real decision maker is. So as long as mom and grandma are agreeing, everything is smooth. It's when they disagree.
I have an idea, or I have an analogous situation. For the vast majority of my patients, they have two equally powerful and authoritative decision makers. I don't know the vast majority, let me say more than half. For most of my patients, they have a mother and a father that are accorded, in my mind and the minds of the staff, equal authority. And so part of our job is to bring them to the same place, wherever that place is. So it's a really good question, who should have final authority when the mother and the grandmother disagree? And I don't have a quick answer for you, except to say, the question could also be, what do we do when the mother and father, when the 25-year-old couple has a baby, and they disagree how to move forward? I'd say, well, what we try hard to do is bring them together, and it's not always easy. But I don't have an answer when a mother and father disagree over who should ultimately be the boss. I know who's the boss in my house, but I put on a good show nevertheless. I don't think I fool anybody who lives in the house or outside the house. But so I hear you, Lainey, and I'm not sure the answer to your question, but I do think there's some analogy that I'm used to working with two equally authoritative individuals in trying to make these decisions.
At the front microphone.
Mark Pyan, I'm a pediatric pulmonologist in San Diego. And this is a question primarily for Dr. Walker, but I'm hoping the rest of the panel will comment also. You touched briefly on a situation where there was a parental request to withhold important diagnostic information. And I'm wondering if you could comment on the ethical and legal responsibilities and constraints that impact on what one does in that sort of situation where either the treatment or the lack of knowledge of that information might be harmful to the adolescent.
I probably will have someone else comment on the actual legal considerations, but in terms of more ethically how dealing with it becomes an issue I can comment on. It's hard, and one of the ones I brought up, having an adolescent who has HIV and the parent doesn't want to know is a particularly hard one for me because it's, most of the time parents don't know when their kids are sexually active, which also, presents a public health risk, and, a lot of things come into the play with that. What I tend to do is first look to where I think how far I can go with that, but talk with the parent and try to find out why don't you want to tell your teen what's going on. What is that? What is the issue? Do you think they're not strong enough? Are they, do you just feel you're protecting them? Because if it's that issue, we can begin to work together on how to explain it. But it becomes a problem if they stay there and I ethically cannot work with a child knowing that they may have risks that they want to keep confidential from their parents, and this information they need to know because maybe they would change some of their behaviors based on the information. So it depends on the situation, but I think it can be very difficult. It takes a lot of talking and a lot of time, I think, with the parent that wants to withhold information from their teenager. On the flip side, I would be very reluctant to have a kid come in alone on their visit and tell them I found out you had cancer. I wouldn't, that is also inappropriate. Or even in some cases when I've had to tell a kid they had HIV and I understand how this kid works and their issues, they need to bring in somebody who's going to be a support for them because many teens can't handle that kind of information on their own, even though they may have the right to come in and find out the results of their tests on their own.
You asked a little bit about the legal side of it. it's not something you're going to see a ton of cases on, so it's hard to predict how it might come out. I mean, I guess if the child needs the information, you're going to have to work with them to figure out a way to get them the information. The law doesn't speak directly to this. It's not, it's kind of interesting. It's looking at the other, almost the flip side of some of this. But adolescents clearly do have rights to some information and information they need to function. You can imagine situations in which parents will come to you and say, my kid's 7, I'm not ready for them to know this information yet. And you might say, okay, we're going to need to think of a plan of how to get this information to them and when we're going to get that information to them. I almost have a hard time imagining court involvement at this point. I mean, you can certainly imagine the later stages, and there are some interesting later cases of kids that came back and said, why didn't you tell me certain information? But most of that really does defer back to professional judgment of, if you think the kids need information, they need the information, and you're going to have to get it to them somehow, but in a way in which you don't dissolve the family unit. So it's not, I'd say the answer is never going to be, I'm sorry, I have to tell the kid, that's my legal responsibility. It's got to be, how do we do this in such a way that the child needs this information, and how do you involved in that, especially if it's information that the parent has known for a while and the child just became able now at this age to start to understand it. So, it's one of those areas where I think using your professional judgment is going to align you legally with what you need to be doing.
I think that's basically correct. I do think that the HIV situation has some special considerations associated with it, because if you have an adolescent who may become sexually active, is in a position to be communicating a life-threatening illness to others without knowing that they're doing it, that could potentially lead to some unanticipated legal liability that there hasn't been a case about yet, but there might be a case about tomorrow. And so although I think what Leslie and Jessica have both said is that you don't want to lead with the legal liability issues in discussing this with the family, you want to work with the family to try to find ways to address this from a clinical perspective and in an ethical manner, particularly when you're dealing with HIV, and there are a lot of statutes and they're changing all the time, and there has been litigation not on that specific issue, and that litigation, will continue to evolve. I think it's important to have the legal concern in the back of your mind as you approach it from an ethical and a clinical perspective, overtly with the family.
Time for one more quick question.
I'll try. So I'm a PA in pediatric critical care, and my question is, we've talked a lot about adolescent mothers of our patients and adolescent pregnant patients, and at least in my practice, most of those pregnancies began with the participation of 2 individuals. And while I understand that oftentimes in other places the boy goes away, in my practice at least, oftentimes the boy is still there. Even if he doesn't want to be, the boy's mother is there and actively trying to participate in the care of the child. And we also know that many of the fathers of these children are not adolescents themselves, again, at least in my community. And so what happens when you have an adolescent boy and an adolescent girl who disagree and maybe neither of them are competent to decide? And what happens if the adolescent girl and an adult male are the mother and father? We often presume that the mother, has the best interest, but what if the mother is a minor and we're not sure they're competent, and the father is legally competent but maybe not terribly participatory? I think that the boys are there, and we should talk about them somewhat. Thank you.
That's an excellent point. You might have
use that on
remembered in
my
the
next
scenario I
exam.
painted out,
That.
I purposefully had the father run involved, because this gets complicated enough. So by bringing the father in, you add another very important layer of complexity. which we can't possibly address this quickly as here, except to acknowledge that you're absolutely right. And I would say very briefly, at least, and perhaps someone wants to speak to his legal rights. I believe where I practice is if he's on the birth certificate as the father, he has legal rights about what happens to this child. Obviously, if he's married to the mother, he clearly has legal rights. But if she's indicated on the birth certificate that he's the father, he has some legal rights where I work, I believe. And again, there are people smarter than me about this who can speak to that. But legalities aside, I do think that if he's involved, that his rights should be taken under consideration as well, and his ability to contribute and help with the child's care while the child's still in the hospital outside should be taken into consideration. Absolutely, that's an important factor. I did have him in that one picture there. He was sitting in the back. He was looking pretty upset, but he was there. And that's a terribly important factor when the father's involved. You're quite right.
My comment was just, it's an exam question, and it's lovely. Thank you for giving it to me. Yes, and in fact, we can make it even more complicated. I mean, as you were speaking about involving the mom the entire time in the conversation, I was like, well, why not the pregnant girl's dad, too, in the decision? Why is it always a mom? And now it's sometimes the practicalities of the situation in front of you, but yeah, I mean, obviously there are other people here. The adult father of the infant has clear decision-making authority, and you cannot exclude him. There are some cases which can really push you on this, which we've had, where we've had questions of paternity come up, even though he's listed on the birth certificate, and the mom knows who the father is, but is unwilling to share because claims her physical safety is at risk. You can make very complicated situations here, but I think, unquestionably, nothing in this gives priority to one parent over another, absent other circumstances. So yes, the father would have a role to play, as would the father of the adolescent who had the child, has a role to play in decision-making related to her, and maybe should be playing a greater role as we say, well, it's a family unit and the support you're making in the decisions. I think all of that will come into play.
That's great. Well, with that, I think we need to wrap it up because we need to head to lunch. But before you go, 2 brief announcements. Just a reminder to please turn in your evaluations, that we want your feedback. And we're going to, if you return your name tag and evaluation, you are entered to win the gift cards. One other brief reminder is that the traffic today is supposed to be unpleasant. So if you need to get to the airport, it might be good to talk to either someone at your hotel or with one of the conference staff about how much extra time you might need to allocate for that. And then we're going to return back here at 1:10 for a very exciting and interesting afternoon session. Thank you.